Welcome, everyone. First, to turn on your Spanish translations, I will read this both in English and in Spanish. Click Show Captions in the Zoom toolbar. Click Select Caption Language or Select Spoken Language, depending on your version of Zoom. Select Spanish. Make sure that translation is highlighted in blue and click Save. You'll then have translations in Spanish. Para activar los subtítulos en español, haz clic en el icono de mostrar subtítulos en la barra de herramientas de Zoom. Haz clic en seleccionar idioma de los subtítulos o seleccionar idioma hablado, depende de tu versión. Selecciona español y asegúrate que la palabra translation o traducción esté iluminado en azul. Haz clic en guardar y ahí tendrás sus subtítulos en español. Welcome to the webinar Community Hour at Home, a program created to support Hispanic Latino patients and caregivers who live with Crohn's disease and ulcerative colitis. My name is Rocio Castrillon, and I will serve as the moderator for the program this evening. I'm a proud Latina IBD patient, originally from Peru, living in Southern California. I've lived with Crohn's disease for over 22 years and have been deeply involved with the Crohn's and Colitis Foundation as a volunteer, patient advocate, and I also now serve as a member of the National Board of Trustees. I'm passionate about advancing diversity and supporting the Hispanic and Latino IBD community. You can find my advocacy work in English and Spanish at Voice for IBD. We have a wonderful agenda planned for you, which includes 2 presentations on IBD 101 and how IBD extraintestinal manifestations impact the Hispanic Latino community. After the presentations, we will have a question and answer session in which you will have an opportunity to ask our presenters questions by typing them in the questions box. Please note that all attendees will remain muted throughout the webinar. Before we begin, I would like to thank our program sponsors, Genentech, Lilly, and Takeda. I am excited to introduce our first presenter, Dr. Priscila Santiago. Dr. Santiago is Assistant Professor of Medicine at the University of Utah in the Division of Gastroenterology, Hepatology, and Nutrition, and she specializes in inflammatory bowel diseases. Her clinical expertise includes diagnosing and managing patients with IBD, such as Crohn's disease and ulcerative colitis. She is dedicated to providing compassionate and personalized patient care, and her research interests include clinical trials in IBD, inflammatory pouch diseases, and the overlap between IBD and primary sclerosing cholangitis. Dr. Santiago will provide an overview of IBD. Thank you for joining us this evening, Dr. Santiago.
Hello, everyone. Thank you so much for inviting me to be able to join here with the Crohn's and Colitis Foundation. And as a Brazilian doctor, I'm happy to be here speaking on behalf of our Hispanic and Latino community. So I'm just going to share my slides. So just going to start with an overview here of understanding IBD. So just a couple of introductory slides for all of us. Second. Okay, so important to talk about IBD as nearly 1 in 100 people in the United States have IBD. And what is IBD, right? So IBD stands for inflammatory bowel disease, which is basically a term that is an umbrella term for chronic long-term immune-mediated conditions of the GI tract. And this umbrella term, it basically functions to explain 2 of those diseases, which is Crohn's disease and ulcerative colitis. Symptoms of IBD and the course of the disease can vary between people, and different people will have different spectrum of symptoms. It's also important to notice that while there is no currently cure for IBD, IBD can be really well managed with different treatments. And over the past 20 years, we do have an explosion of new advanced therapies for IBD, and we also have non-medical treatments options available for patients to take in conjunction with their treatments. So it's also important to know that there is an increase in incidence in IBD over the United States. And by 2050, it is estimated that 54% of the US population will be from diverse communities, mainly Hispanic and Latino communities, and also the African American community. So we know that IBD incidence is growing, and it's also more disproportionately growing higher and higher in those minority groups. For example, the current cases for white people with IBD are around 21 cases per 100,000 persons a year of incidence, and non-white around 13 cases per 100,000 persons a year. But it is expected that over the next 40 years, there will be an increase in 39% of the cases in white patients with IBD versus 135% in non-white. It's also known that IBD is also increasing its incidence in people who immigrated to the United States from diverse communities. Just a brief overview here of the two main conditions, Crohn's disease on the left and ulcerative colitis on the right. So Crohn's disease, as we know, can occur in any part of the GI tract, from the anal canal to the mouth. So it's a patchy disease, and we say it's usually a discontinuous type of inflammation. So we have areas that have inflammation and areas that skip inflammation and have normal lining of the colon in those areas. So basically, it is a disease that commonly affects the small and the large intestines. As opposed to ulcerative colitis, which is on the right, is a disease of the large intestine. And as the name says, colitis, it comes from the colon, so the large intestine. It's usually, we say, a continuous inflammation that starts in the bottom, it starts in the rectum and goes up. So some patients will have inflammation just in the bottom in the rectum, and some patients can have inflammation and pancolitis, which would mean the whole large intestine is involved. Common IBD symptoms include chronic diarrhea, urgency, so a lot of rush to go to the bathroom, have a bowel movement, blood in the stools, mucus in the stools, abdominal pain, cramps, nausea and vomiting, some fatigue as well. Those are mainly common symptoms, common abdominal bowel symptoms. However, we do know their IBD can affect different areas of our bodies, and that's what our next speaker, Dr. Quezada, is going to be talking about, the extraintestinal manifestations. And also important to notice that even though those are the common IBD symptoms, it doesn't mean that if you have those symptoms, you have IBD. If you're experiencing some of those symptoms, it's important to talk to your provider to start at least investigating those symptoms. And IBD as well, we don't know the cause. There are several different factors that play a role in causing IBD, and those are the most important brackets here. So environment, such as some dietary components, smoking, some medications, genetic components. So there are some genes that have been associated with Crohn's disease and ulcerative colitis, and we also know that patients that have a family history of a parent that has IBD have also a slightly increased risk in getting IBD themselves. It doesn't mean they will get IBD, but there is definitely an increased risk in that population. The gut microbiome is also very important in IBD and overall inflammation in our intestines. So basically, there is a lot of gut bacteria and fungal organisms that live in our bowels, and they can get dysregulated with ongoing inflammation and a stimuli from the outside. And we know that, like I mentioned, IBD is a chronic inflammatory disease. So our immune system is kind of like responding to all this stimuli and provoking more inflammation in the lining of the intestines. Also, diagnosing inflammatory bowel disease involved multiple testing. So it's not one single test that will get to a diagnosis. So it's important to have a visit with a provider in the GI clinic, collect a medical history, the symptoms, a physical exam. Your doctor is also going to be doing blood tests and stool tests to check on the possibility of those diseases. And most importantly, an endoscopic examination with usually a colonoscopy and taking tissue samples that we call biopsies during the colonoscopy to really get a confirmation of the diagnosis. Some imaging tests are also used to diagnose and to monitor some types of IBD, especially with Crohn's disease. So you might encounter need for a CT scan or MRI of the abdomen. Nowadays, there is also intestinal ultrasound, some centers that are doing for diagnosing and monitoring IBD. And this is a QR code to learn more about this topic with the Crohn's and Colitis Foundation. So IBD treatments may include multiple steps in treatment. So from medications to diet and nutrition and also surgery. As important to know that all treatments for IBD, they're aiming to target the inflammation and also helping relieving the symptoms. So with help relieving the symptoms, we mean by achieving a clinical response. That's like the medical term that we like to say. And also with the goal of a clinical remission. Remission meaning having an inactive state where we turn off the inflammation. It's also important to note that not only we want the patients to feel well and recover their health, we also aim to heal the intestines lining. So when you have a next colonoscopy, we don't see more inflammation. We see just everything is healed up. Several different medication types are available. Will depend on the type of inflammation that you have, also on the severity of the inflammation, your comorbidities. So those are just several types of names of medications. For example, steroids might be needed short term in the beginning, but overall, most of our patients are either, if they have a mild case of ulcerative colitis, that you either using aminosalicylates, which would be like mesalamine. But if it's Crohn's disease, or if it's a more not so mild disease, most of our patients that use advanced therapy that we call biologics or small molecules. More information, there's also in Crohn's and Colitis Foundation. This is just an overview. So basically, and finally, our treatment goals when we're treating patients with inflammatory bowel disease include: number one, to induce remission. As we discussed, remission is an inactive state. So basically, our goal is to turn off the inflammatory signal and heal the lining of the colon. So the healing, we're able to see that with endoscopic procedures. We also, with this stage of inducing remission, is also our goal to normalize the symptoms, normalizing the labs and the stool markers of inflammation. Then proceeding with the next stage would be maintenance of remission. So maintaining a state where patients can feel well for a prolonged period of time and not have a flare-up of the disease, meaning not having a relapse of symptoms. It's also important to do a lot of prevention of complications, prevention of infections, prevention of colon cancer in patients with inflammatory bowel disease. And we monitor patients most of the times when they're on medications. We monitor every couple of months with lab work and blood work and stool work. Finally, is also very important goal is to improve the quality of life of patients. Of course, we all acknowledge that inflammatory bowel disease causes a lot of disruptive symptoms in the lifestyle of patients. So our goal is that you are able to go to work and enjoy your social events and enjoy life and achieve good quality of life. So thank you very much. That was just an introduction. I will pass it over to Dr. Quezada.
Thank you so much for that wonderful overview of IBD. It's a great information for those of the newly diagnosed, and it's also a good refresher for those of us who are seasoned patients. As a reminder, you can enter your questions in the Q&A box, and we will be answering them at the end of the webinar. At this time, I'll introduce our final presenter for this evening, Dr. Sandra Quezada. Dr. Quezada is the Associate Dean for Admissions and Associate Dean for Health Strategy and Engagement at the University of Maryland School of Medicine in Baltimore, Maryland. She's Professor of Medicine in the Division of Gastroenterology and Hepatology, and her practice and research interests center on delivering high-quality, equitable, IBD care. She is also a national board trustee for the Crohn's and Colitis Foundation. Dr. Quezada will discuss how extraintestinal manifestations impact Hispanic and Latino IBD patients. Thank you for joining us this evening, Dr. Quezada.
Excellent. Thank you so much, Rocio. And Doctora Santiago, if you could stop sharing your screen, that would be awesome. And then I'll start sharing my screen. There we go. Perfect. So I'm going to go ahead and pull my slides up. And while I'm doing that, I just want to acknowledge a couple people, actually. Am I sharing the right screen? Is this working, Rocio?
Yes, but we can also see your wall. There we go. It's perfect.
Excellent. Okay. Well, I just want to thank the Crohn's and Colitis Foundation for hosting this webinar, and Kanika McNeil, who's in the background, but has gone through a lot of effort to put this together today. So kudos to the foundation and to its staff, and certainly to Rocio Castrillon, who's just this remarkable person who's transformed her experience living with IBD into inspiration to educate and advocate for other patients. So I'm honored to be on this panel with Doctora Santiago, and I appreciate her overview of IBD in general. And now we're going to talk about how IBD can also affect parts of the body that are outside of the digestive tract, or what we call the extraintestinal manifestations. And my goals with this part of the presentation is that hopefully, as I'm presenting, we're going to answer these 4 questions. How does IBD impact the Hispanic and Latino community specifically? What are extraintestinal manifestations and what types of extraintestinal manifestations exist? And then finally, as a patient who is Hispanic or Latino and has IBD, what kinds of extraintestinal manifestations might be helpful to be mindful of? So let's start with that first question. How does IBD impact the Hispanic and Latino community? What we know from several studies that have shown actually that there actually are some higher risks and likelihood among patients who are Hispanic or Latino that have IBD of having what we call perianal complications. So complications or manifestations around the anal area. And also in patients with ulcerative colitis, they're more likely to have more notable rectal bleeding than other patients. Also, patients who are Hispanic or Latino tend to report more problems with being able to control their symptoms, sometimes lower health-related quality of life, and also concerns about medications. And that could mean a lot of things. It could mean concerns about what are the risks of taking some medications. It could also mean concerns about costs of medications. But also we've seen that sometimes even accessing those medications or accessing specialty care, whether it's seeing a gastroenterologist or even more specifically an IBD specialist like Doctora Santiago, for example, can be more of a challenge, and oftentimes have to resort more to going to the emergency room. So these are some of the ways it impacts the Hispanic community specifically. Similarly, once they do seek out care in the hospital setting, it seems that Hispanic patients are actually hospitalized less often than white patients, which you could see as potentially maybe that's a positive. But then when they are hospitalized, they seem to actually be higher costs. And to me, that communicates maybe it's because maybe we're waiting a little too long to really get the treatment that we need. So then by the time we get to the hospital, there's a lot of work that needs to be done, and there are potentially more costs also associated with that. In some settings, Hispanic patients are less likely to undergo surgery, but what has been shown is after surgery, there's actually a higher odds of having to be readmitted to the hospital, meaning after the surgery and they were deemed safe to go home, they actually have to come back to the hospital sooner than we would expect or we would want to. And that's something that we see more often among Hispanic patients. And again, questions for why that may be, but it could be, again, if we're not well connected with the outpatient care, sometimes that can be part of that. So moving on to our second question, what are extraintestinal manifestations? So these, as I mentioned before, these are complications and manifestations associated with IBD that actually affect the body or parts of the body that are outside of the digestive tract. And interestingly, they can sometimes manifest before someone even knows that they have IBD. So sometimes this can be sort of the first sign of something beginning to develop, sometimes even by several years. And not all extraintestinal manifestations have the same pattern of when they manifest. So just like I said, some can happen even before you have a diagnosis, others develop after the diagnosis, but also some of them tend to act up and are reflective in a way of the inflammation that's happening in the gut. So the inflammation in the gut is mirrored by that manifestation outside the gut, but not always. Some of these actually kind of are unrelated in some ways and really are unpredictable and can actually sort of rear up and become inflamed even when things are going fine and well controlled in the gut. So they can be independent. There are a lot of, I would say, medical terms here, but I think it's helpful to see them because we're going to kind of break down what each of these terms are. And this way, you're a little bit more familiar with them if you see them in the future. But really what we're doing here is categorizing 5 different places or ways in the body that these extraintestinal manifestations can develop. So the first being the musculoskeletal is really talking about bone and joint areas versus cutaneous, we're talking about skin related manifestations. Ocular are those that have to do with the eye. Hepatobiliary is the liver and bile duct areas. And then there are some others that are, don't quite fit in any of those categories. So like I said, over the next couple slides, we're gonna explain a little bit more about what each of these conditions are, so you have that awareness. So first talking about those joint manifestations or the musculoskeletal manifestations. And the most common of these is definitely arthritis. We usually, even up to about 1/3 of patients with IBD may experience this at some point. I can tell you among my patients, this is definitely the one that I hear about more, that there are some associated joint swelling. And depending on the type of, again, joint manifestation, sometimes it mirrors what's happening in the gut, but not always. Sometimes it can be in some ways very independent of that. But it really is an inflammation of the joint. So again, the pain, but also some redness, some swelling, and it can really affect patients, certainly their function, their mobility, and just how active they want to be. And it can affect peripheral joints, meaning those in the limbs, your arms, your legs, hands, feet, but also some of those more central or what we call axial, meaning the spine, and particularly ankylosing spondylitis is one that really involves that lower portion of the spine. So the peripheral arthritis, again, are those that are really involving the arms and the legs, usually affecting more of the larger joints of the arms and legs. And this is one of those that actually does mirror what's happening in the gut. So if we're able to have improvement in the gut, you'll also get that improvement of the joint swelling and pain. And the good news is it does not seem to be associated with any permanent damage. So again, it's reversible. When we can get the controlled inflammation, then your joints actually can revert back to their baseline. So this is part of the good news, I would say. And more often we see this in patients who have the colon involved. And one thing I'm just going to throw out here, I'll add, is we have a lot to learn still about why this is happening and how exactly it's happening. There are a lot of people who are studying this to understand, for example, this connection of the colon with these peripheral joints. It's something that we need to learn more about why that is. And then the axial arthritis, or those that involve the spine and also the sacroiliac, meaning those hip joints as well. These are one of those that potentially can happen before a diagnosis of IBD. I actually had a wonderful young patient who did have that lower spine involvement about 2 years before her diagnosis of ulcerative colitis, in fact. So this is an example too, though, that if we can treat the inflammation with the same medication sometimes that we might use to treat the inflammation in the bowel. And so sometimes you can get sort of a 2-for-1 benefit out of good IBD therapy. It can help keep the bowel inflammation under control, but it also helps treat what's happening outside the gut. Here's just some images to explain what ankylosing spondylitis looks like. So again, this is really that lower or lumbar area of the spine, and as it goes into the hip, it is very noticeable. And this is one where you really want to be proactive in taking care of that inflammation, because it can actually sort of stiffen over time and create more stiffness in that area for patients. So we definitely want to make sure that we diagnose it and treat it appropriately. And it can be treated with, again, the same therapies that we use to treat inflammatory bowel disease of the gut, either with biologics or with these newer small molecule or the pill treatments, advanced therapies. And it's actually more often seen in younger men. But like, as I said, I had a patient who was a young woman. So it certainly, it can affect both sexes, but we more often see it in male patients. So let's shift gears to talk about the skin manifestations. This is not as common. So remember, the joint was more like a third or 30%. This is about half the case, but still not that rare. So, 15% of patients with IBD at some point may have a skin manifestation. And these are a few examples, and they're very, I don't know. I think the words are not like common words. So, and maybe because these are more rare manifestations, we don't often hear as much about erythema nodosum, pyoderma gangrenosum, or oral aphthous lesions. But this picture here is actually showing an example of erythema nodosum. And I'll tell you all, I actually, when I was a medical student, I got erythema nodosum the summer between my 3rd year and my 4th year, and it was on the shins. It often does manifest on your shins or on your forearms. There are these red bumps. Mine were actually bigger than here, but they're quite painful. And usually, again, if it doesn't resolve quickly over time, it can be treated with something like a quick steroid or something that will help. For, again, as a patient who did not have IBD, that would have been the treatment. With IBD, we can use other medications. It does tend to be self-limited, though. It's not something that you expect to have as a long-term complication of IBD. It does respond with IBD treatment. And also, I actually did a lot of these non-medical therapies that help, just raising your leg just like you would to reduce any kind of swelling in the legs, elevating the leg, using compression stockings. I did all of these things. And analgesics or anti-inflammatory. So I remember I was taking some anti-inflammatory as well, which at least also helped with some of that discomfort. But mainly it was raising the legs, and I would put a little ice on there sometimes to help with the discomfort and the swelling. The oral aphthous lesions are actually lesions that are like almost a little flat, little ulcer sometimes on the inside of the cheek. And they can be like almost like a little canker sore sometimes. So this is actually something that we see more often in our patients with Crohn's disease. It does tend to mirror what's happening as far as inflammation in the gut. And it does respond to, again, standard IBD therapies. Sometimes we can do some topical treatments as well. And then the pyoderma gangrenosum, which fortunately is probably one of the more rare manifestations that we don't see. This is like erythema nodosum, but elevated to something that's, it's actually more aggressive. It tends to get, the areas get more ulcerated. And it really is a very painful manifestation. So again, something that you want to recognize early and have a physician evaluate, or dermatologist, or your primary care, your gastroenterologist, see what's going on so that they can make sure you're getting the appropriate treatment before you let it progress. And then it's important to note that, like with any medication, sometimes there are some reactions to medications. These are very uncommon, but it's possible that some skin complications can be not from the disease itself, but related to some of the treatments. And there can be sort of a broad range of, how minimal or mild we might see it. In the anti-TNF agents, so these are like infliximab or adalimumab, some of the drugs that have been around for a longer time. Sometimes they can cause a rash similar to like a psoriasis, if you've heard of that type of rash that is an autoimmune manifestation. Sometimes I've seen individuals who get a little bit of hair loss related to these, so that's another manifestation. And this is something that oftentimes can be managed in partnership with your GI doctor as well as potentially a dermatologist. Ocular manifestations are those that affect the eye. And so these also, again, are some of the more rare complications. Only 2 to 5%, it's estimated, may develop in eye complication related to IBD. And some of these can sometimes be also related to a medication versus some of them being what we call primary, that it is simply a true manifestation or extraintestinal manifestation of the IBD itself, and not necessarily a reaction to medication. But we know that sometimes steroids themselves can have some different ocular manifestations as well. So this is one of the primary ones, that this is not about the medications. This is related to the inflammation related to IBD itself, and that's episcleritis. So anytime you see itis, it means inflammation, and then whatever is in front of that is the area of the body or part of the body that's inflamed. So in this case, episcleritis means that the episclera is inflamed, and the episclera is that superficial layer that's clear and right on your eyeball, basically, that's covering the eyeball, and that can get inflamed. And so as you can imagine, it's going to cause a burning and painful redness kind of sensation there in the eye. It does correspond with what's happening in the gut. So you definitely want to make sure that you're appropriately and aggressively treating the underlying inflammatory bowel disease in the intestinal tract, but also in some cases it's helpful to have some directly applied topical steroid treatment to the eye. And again, this is one where it really should be your GI doctor with an ophthalmologist or an eye doctor would want to see that too. Whenever I've had a patient who's mentioned any kind of eye symptoms, I pretty quickly refer them to see my colleagues in ophthalmology, just to make sure that we're catching anything that might happen there quickly. Scleritis, again, this is now the inflammation of the sclera, that's the white part of the eye. So that also can cause pain, it can cause tenderness. And similarly, we'd want to make sure that we're treating the underlying IBD and potentially adding any additional topical steroid to get that kind of cool the area down and help get that inflammation under control. And then finally, uveitis. So the last three I've just said, the episcleritis, scleritis, and now uveitis, these are all considered primary, meaning this is the IBD itself can, again, in very rare cases, 2 to 5%, maybe have this manifestation in the eye just from the IBD itself. So this is that middle layer of the eye. And it includes these three parts. It includes the iris and also basically some of the cords that are holding those areas in place. And essentially, when any part of this core portion of the eye is involved, we call this uveitis. This, in addition to the pain, this is actually can cause some visual disturbance. So you can get some blurry vision, sensitivity to light, and some headache. This one can also manifest before the diagnosis and doesn't always correspond with what's happening in the gut. This is again, you're noticing the theme now. Treat the IBD, and when needed, potentially add some additional topical steroid or biological therapy. And those were the primary. There are some secondary conditions or some reactions that we might see in the eye that are more related to the treatments that we see. This is also very, very rare. But for example, steroids are known to potentially be associated with cataracts or development of glaucoma. So certainly in anybody who's on higher dose steroids and long-term steroids, definitely something to be mindful of. Is, I would say, the glaucoma in particular. Methotrexate has been associated with having pink eye as well as some dry eyes. And again, those anti-TNF or some of these older medications that we still use very much to treat IBD can also actually interestingly cause a uveitis, which is basically the sort of opposite of what you would expect that it would do, since it reduces inflammation, but sometimes there is this sort of paradox response. And what I want to stress here again is these are rare complications, in particular with regard to the anti-TNF or the methotrexate. Certainly we have these conversations with our patients and remind them that usually the risk of not being on the right medication is greater than the risk of any of these potential complications, but it's helpful to know that the possibility exists so that if you ever experience symptoms, you can really be proactive in contacting your provider and getting it addressed as soon as needed. I think this is one of the last sections. We're talking about the hepatobiliary, or that liver and bile duct complications. So primary sclerosing cholangitis, which we learned recently is one of Doctora Santiago's areas of interest. This is where basically the liver and the bile ducts within the liver also exhibit some inflammation. It's sort of an interesting relationship where it's not that common in somebody who's first diagnosed with IBD. We see it maybe in 5% of patients who first had that diagnosis of ulcerative colitis, even less than that in patients with Crohn's. But the reverse is different in that if the patient first presents and has a diagnosis of primary sclerosing cholangitis, or that's a mouthful, so we call it PSC for short, then we usually do a colonoscopy and we assess for the possibility of IBD. And it's actually very common among patients who already have PSC. As you can see, 60 to 80% of patients who have PSC ultimately also will have a diagnosis of IBD. So something to be aware of. Again, more often we see this among male patients, patients who have pancolitis, meaning that the entire large intestine or colon is involved. More often in patients who are not smoking, not that I'm saying that you should smoke to avoid this, it just happens to be the case, and also in patients who've had their appendix removed. There are some blood tests that can be done, and they're actually common tests, especially the elevated alkaline phosphatase. That's a blood test that's a commonly checked one, just sort of looking at how healthy your liver is. So if that's elevated or if it's high, that can help sort of raise a flag and be a signal to your primary care provider and or to your gastroenterologist to complete a more full evaluation to make sure that this is not potentially what's causing that elevation. It actually does not necessarily have a parallel with the intestines in terms of its flares or manifestation. But a really important thing to know is that those patients who have this diagnosis of PSC and also have colitis actually have a much higher risk of colon cancer than say patients who have IBD, but they don't have this primary sclerosing cholangitis. So because of that 10-time increased risk, the moment that we know that both of these things are, that the patient has both diagnoses, then it means we need to make sure that you're on a very appropriate monitoring for colon cancer and get colonoscopy within, essentially at the time of that diagnosis of both conditions, and then every year after that. Okay, I was wrong. I do have another graph. I'm going to try to move a little more quickly. So we have pulmonary manifestations in the lung. These are pretty rare, but it could be that there is inflammation or manifestation in the airways, what we call the parenchyma, which is basically the actual tissue of your lungs, the pleura, which is actually the membrane around the lungs, and the pulmonary vasculature, the blood vessels that supply the lungs. Essentially, this is interesting in that because the tissues that ultimately develop into your airway and your respiratory system come from the same place. You can say when we were just still developing in our in the womb, it's from the same place that the digestive tract developed. So interesting that there is that parallel there. So the main thing I'll focus on just in the last couple minutes here are for patients who are Hispanic and Latino and have IBD, what are some extraintestinal manifestations in particular you might want to be mindful of, or make sure you get an evaluation for if you think you have symptoms. Certainly the joint symptoms, which is, they're the most common ones in probably all populations, and the Hispanic Latino community is no exception. Also, those little oral lesions, I mentioned the little flat ulcerations that sometimes can develop inside the mouth. Some of the skin conditions that we talked about, and the eye involvement of uveitis, and then finally liver related complication, or the primary sclerosing cholangitis, is one that's reported. Again, of these, it is the least common. So as you can see, there really are different parts of the body that just kind of shows that inflammatory bowel disease really is a systemic disease. It tends to really focus its activity in the gut, but it can have these manifestations outside the body, in theory, in really any organ. Most often you're going to see it, though, if you do at all, in the joints, skin, and eyes. Sometimes they correlate with the activity again. And while some drugs can create sometimes some secondary complications, for the most part, they are the right treatment for helping to get these manifestations under control. And sometimes they can even help guide your doctor to choose which drug might be the best one for you because of the different mechanisms of drugs that we have today. And as I mentioned before, this is usually something that, your gastroenterologist is going to really want to have a really collaborative and multidisciplinary approach. Make sure that we're including specialists of the eye, specialists of the joint, specialists of the liver, et cetera, to make sure that we are, and dermatologists, to make sure that we are giving you the highest quality of treatment possible. So I'll end there, and thank you all very much.
Thank you, Dr. Quezada. That was a wonderful presentation and very informative as a patient who's gone through many EIMs myself. So at this time, we will transition to our question and answer session. I'd like to invite both Dr. Quezada and Dr. Santiago back to answer questions from the audience. As a reminder, if you have questions, please type them in the Q&A box and we'll try to answer as many as we can. I'll go ahead and start with the first question that we have, which is a patient stating they have sores by the rectum and or vagina, and they're asking if it's possible that they're caused by Crohn's disease.
Sure, I can start there, and Dr. Santiago, if you want to chime in as well. It is possible, actually. So certainly sores around the rectum, and I guess one thing that would be helpful to clarify is if they feel like they're openings or if they're draining, then sometimes that's actually one of those what we call perianal complications, where essentially there's like a little tunnel that has formed from the rectum to the skin around the anal area, and there can be a little drainage there. Sometimes before it's opened up and started draining, it might just feel like a little bump, that a little painful sore around that area. I also want to acknowledge that there are some skin conditions that can also sometimes cause sores. A lot of the time it's right in the midline and right above the anal area, and that's called hidradenitis. So sometimes that's another possibility. And then similarly around the vagina, you can also have some of those manifestations, some of those little, call like fistula, or those little tunnels that develop sometimes can be seen around the vagina. But one other thing I'll mention is there is also another autoimmune condition that causes sores around the vagina called Behçet's, and oftentimes those also have sores in the mouth and the vagina. But it's really the summary is you should definitely have your doctor examine that for you, because as you can see, it could be a number of different things, and it's definitely not something that you want to allow to sort of progress. You want to make sure that it's diagnosed and treated early. Doctora Santiago, did you have anything you wanted to add to that?
No, I love what you said. I would definitely agree. Whenever a patient is complaining of perianal, meaning symptoms around the anal canal, it's very important to bring the attention to the doctor and to have an examination in clinic, right? At least a physical exam of the area to look and kind of see, because it might be more difficult for the patient, for you, right, that you're having the symptoms, to see if there is a drainage or no drainage, or if there is an opening or no opening. So it definitely helps to have another eye, meaning a provider eye, to see what's going on, because even though those things are very important and could be related to inflammatory bowel disease, there are also benign conditions, like meaning normal common conditions of the anal area, right? Infections, and there are hemorrhoids that could be bumpy and lumpy around the area, that it will be better examined if you have a clinician looking at those areas. And if they come and we think they're related to inflammatory bowel disease, there is specific tests and imaging and treatments for those conditions. So I'll definitely have that discussed in your next clinic visit.
And I see
Thank you both.
Yes, I see another EIM related question, just the comment that this is from Raquel Thompson. Thank you for this comment, that you were surprised what I mentioned, hidradenitis suppurativa, or HS, wasn't necessarily on the list or on the slides. And you know, it's an interesting comment. I welcome that feedback. I think it's certainly something that we could include in the future, just so folks again are aware of that. And even physicians, gastroenterologists and dermatologists alike, sometimes it can be a struggle to distinguish between, is this hidradenitis, is this is this something else? But it hasn't often been sort of classically or historically been categorized as an extraintestinal manifestation per se, but it certainly is associated and something that we do see commonly in patients with IBD. To be honest with you, I'm not aware of studies that have shown that it is necessarily more common in the Hispanic or Latino community. Anecdotally, though, I can tell you, and I do think I have seen studies. I practice in Baltimore. We have a very prominent. I have a lot of Black patients with IBD, and we do see quite a bit of hidradenitis more often among my Black patients, more often than my white or Hispanic patients, actually. But I'm not sure that this has really been studied directly, so that is something to look out for.
Great, thank you. Well, this next question is not EIM specific. I don't know if either one of you would like to answer what the best dietary recommendations for IBD patients are, and if there's any particular food triggers. I know it's a broad question, so I know you maybe The short version
can
of the
start,
answer.
yes, I can start answering. Dr. Quezada can complement with her experience as well. So usually when I'm discussing diet therapy for patients with IBD, I definitely want to have like a multidisciplinary approach and have a dietitian talk to my patients, because of course our training doesn't, as medical providers, we didn't get extensive training in diet and nutrition, but overall, the diet that I am recommending for my patients is the Mediterranean diet, right? Mediterranean diet meaning is diet that has been studied for different other conditions, heart diseases, cholesterol diseases. So it's a diet that has improvement in inflammation in other parts of the body, and it has been studied for IBD, and in Crohn's disease there is actually a direct study that compared the Mediterranean diet with a more specific and more restrictive diet, and it showed that Mediterranean diet was similar from the more restrictive diet. So Mediterranean diet is basically eating whole foods, eating more organic, meaning avoiding processed foods, avoiding very high sugar, avoiding basically I would say like processed food, highly industrialized foods, and eating a lot of cooked vegetables, eating lean meat, fruits, depending. So basically there's another distinction as well. So the Mediterranean diet, I start talking about this when we have a patient that is with symptoms of being inactive Crohn's disease or ulcerative colitis, right? More like towards remission, not in an active flare-up. In active flare-up, it might be difficult to eat all those fibers and all this, the veggies that a Mediterranean diet has, but it's for a disease of maintenance of patients, meaning maintenance of the disease status when they already calm down the inflammation. That's a great diet because it's basically full of good sources of fibers, veggies, and lean meat. There is study showing also like for ulcerative colitis, avoiding a lot of red meat could be helpful, but that should be determined as well with your dietitian and your physician. But overall, avoiding like really junk food, avoiding fast food and those processed foods is helpful.
I agree 100%. And I just wanted to put a plug there for Dr. Oriana Damas at University of Miami, who is doing good work in studying what are some foods that we often enjoy in the Latino diet and more Caribbean diets that also might have some great anti-inflammatory properties. So I think that, you know, the results are still pending to some degree, but one of the things that she shared with me already is that there is a signal that it looks like yuca may have some great anti-inflammatory qualities about it, which is great news because I love yuca. Although probably we shouldn't be frying it so much. So other, you maybe boil it. It's still delicious. But also curcumin or turmeric has been shown to have potentially some anti-inflammatory properties. And they're studying even cumin potentially, which we use a lot of cumin or comino in our diet. So I think that Dr. Santiago is right on that, generally speaking, a diet that's going to be lower in processed food, more natural food, not as fried foods, etc., I think is definitely going to be a better way to go. But one thing that I'll say too is it's very individual. This is one of those places where each patient is going to really have control and really be able to monitor how does your body respond to those foods, because some people say like, oh, well, I eat spicy food and I have to go straight to the bathroom. And then other patients are like, it's fine. I can eat all the spice I want. It doesn't change anything. And then I say, that's great, because they think I'm going to tell them you can't have any spicy food. And no, there have been no studies that show that spicy food increases inflammation in the gut. So it really is more about how does it make you feel and how is it tolerating. We're still learning which foods potentially can be more protective for inflammation in the gut. And
Great, thank you.
somebody, oh yeah, somebody's asking about supplements. You know, again, I mean, I just mentioned curcumin. I mean, I think that there are things that we still need to learn more about, I would say just make sure that you're sharing with your gastroenterologist and your provider, your doctor, what are those supplements that you're interested in or that you're taking, so that they can come along with you on that journey and do the research and make sure that there isn't a downside. You know, sometimes there are some that it seems like they're very low risk. We're not even sure that much how much it helps, but as long as, usually if I tell my patients, I know it's not going to hurt you, then I'm okay with you trying it and seeing if you feel a benefit. But not just know that just because it's natural or not a medication doesn't mean that it can't necessarily harm you. You know, like even mushrooms can cause liver failure, you know, the wrong mushrooms, right? So just, you know, it is, I think, I'm always open to that, but I would say make sure that you are informing your doctor so they can give you some guidance there.
Great, thank you. Do you have one final question? How do comorbidities, for example, diabetes, obesity, cardiovascular disease, how does that influence the presentation of EIMs in Hispanic Latino patients? Or does it?
You know what? Actually, that's interesting because in the interest of time, I didn't cover, there was one slide that does talk about some of these even more rare potential extraintestinal manifestations, like there are some cardiovascular manifestations as well, some neurologic ones that are very rare. I would say overall, those proportions that I shared, as far as, you know, with the arthritis being 30% and the oculars are only 2, or we haven't seen studies that show that having one of those comorbidities now changes or raises your risk of having one of these extraintestinal manifestations. I think what it might do more, though, is that it means that we need to balance what are the medications we're going to use or treatments we'll use to adjust that with potentially what are the other medications you're already taking for some of these other comorbidities. So you know, having other comorbidities always means that we have to have a longer conversation and make sure that we're really thinking about all the things that, you know, might be part of your treatment plan to make sure we're balancing that well.
Just another add-on. And we do know that there is research showing that some cardiovascular diseases, some patients, that have an inflammatory bowel disease, there's uncontrolled and have a lot of inflammation, might also trigger some cardiovascular events, right? So it's not you will have those, but it's just like an inflammatory burden, inflammatory state, and could predispose to have a more heart issues in the IBD population. So that's another reason for us to really try to treat as much as we can the inflammation to avoid any further complications, even though we don't call this an extraintestinal manifestation per se, would be just consequences of inflammation in the body.
Thank you both. And I'm going to go ahead and answer this last question about the dining situation in college, because the Crohn's and Colitis Foundation offers a number of resources as it relates to diet and nutrition. In particular, there's a website called Gut Friendly Recipes, and the website's gutfriendlyrecipes.org. And there you can find a number of different options based on your personal preferences or dietary preferences, or if you're going through a flare. It's a great resource for patients. In addition, the foundation has recently developed a series of YouTube videos, which kind of address a lot of these questions, which is what are the best proteins, what are the best grains, fruits and vegetables, what's the best way for patients to consume these? And so those are all available on the Crohn's Colitis Foundation's YouTube channel, so that can help guide you. So that concludes our Q&A. As we close for the evening, I'd like to thank both our presenters, Dr. Quezada and Dr. Santiago, for providing us with insightful information about Crohn's disease and ulcerative colitis and EIMs. The Crohn's and Colitis Foundation is grateful to have healthcare professionals partner with us and provide informative presentations to the IBD community. So thank you both again. I also want to thank our sponsors, Genentech, Lilly, and Takeda. And last, but certainly not least, we want to thank all of our attendees for joining the webinar tonight. We hope you gained insightful information about IBD and how it directly impacts the Hispanic Latino community. Before you log out tonight, we ask that you complete the brief evaluation form we've placed in the chat box and on the screen. The link and QR code will take you directly to the survey, and evaluations will help us develop future programs. We also encourage you to continue your IBD learning journey with us. We have several resources to support the Hispanic Latino community. We have a Facebook community, a monthly Spanish-speaking virtual support group, and a comprehensive Spanish language website. You can scan the QR code on the screen for more information. And if your questions were not answered tonight, I encourage you to visit our website for more information. The website is Crohn'sColitisFoundation.org. You can also contact the IBD Help Center at 888-694-8872. They do provide assistance in over 170 languages, and you can contact them via phone or email. The email address is info@Crohn'sColitisFoundation.org. Thank you again for joining our webinar, and have a great evening.
Buenas noches. Thank you.
Thank you.
Thank you. Gracias.
All right, that's it. That's everyone.
Oh, that's right. I forgot we're 4.
Yeah, I was thinking the same thing, and then I was like, wait,
those
I think
persistent 4.